opportunity, and senior professors, Dr. Jagdish sir and Dr. Srinivasan sir, for coming for the session. So our brief aim of this, without taking much time, main aim of this session is asthma always remains a topic which is easy to read, but it is quite difficult to practice. Our main aim is to get to the real how to achieve adequate control for a child with asthma. When is he going to become difficult? How to anticipate that? What are the steps in the evaluation? And we wanted to go through from basics to biologics in a sequential manner, addressing all the hurdles which we usually encounter in a practice. Though the incidence of real severe asthma is much less compared to the Western population, we thought that this will be a very good session, which we aim to make it more practical. So I will introduce both our speakers for the session. First session, for the first 20 minutes, about a brief case, we'll be discussing with a real life case discussion by Dr. Keerthana from Children's Hospital. And after the case summary, it will be taken over by Dr. Kavita from Rainbow Children's Hospital, who will be getting through the details. She'll be discussing about the case as well in coherence with the current GINA guidelines, and she'll be covering from basics to biologics and with a scientific and practical approach for all the attendees. Thank you all. So we can start the session, and Dr. Keerthana you can start sharing your slides and your case.
Is my slides visible, sir?
Yeah, these are visible.
Good evening, respected teachers, seniors, and one and all present. I'm Dr. K from Childress, and I'll be presenting a case on poorly controlled asthma in children. So the learning objectives for the day will be to recognize poorly controlled asthma.
Dr. Keerthana, please switch on your video. Always be more effective if your video is on. Your video. I don't see your video in your box. No, you are not visible, Dr. Keerthana.
Yes, sir. I've switched on the video now, sir.
Yeah. Thank you. Thank you very much. Thank you. Thank you.
The learning objectives for the day will be to recognize poorly controlled asthma, the approach to difficult to treat asthma systematically, and to identify the modifiable risk factors before escalation of the therapy, and to discuss severe asthma evaluation, and to review the biologic therapy considerations. So the case is, this is a 9-year-old boy who had recurrent wheeze since 4 years of age. He has background history which was suggestive of asthma. So now his current symptoms are recurrent cough and breathlessness for 6 months. He also had frequent reliever use for 6 months. He had breathlessness on exertion for the past 5 months. He had night awakenings due to cough for the past 4 months. So history of presenting illness, he was well till 4 years of age, and then he had recurrent cough and wheeze for the past 6 months. His symptoms were triggered by seasonal changes and viral upper respiratory tract infections. Now he's having progressive worsening over the last 6 months. He's also having night and early morning symptoms, and for this he requires reliever at least once daily. He has exercise-induced cough with interruption of running and outdoor play. He has nocturnal cough, breathlessness for around 3 to 4 times per week, which is very significant. He also has allergic rhinitis and conjunctivitis symptoms for past 2 years. He also has recurrent OPD visits for exacerbations, and he does not have any persistent wet cough or poor weight gain. He does not have fever, weight loss, or TB contact. There is no voice change during such episodes, no heartburn or regurgitation. There is no recurrent ear infections, skin abscesses, or severe infections. There is no persistent nasal discharge since infancy. Chronic nasal blockage is not there, and also there is no hearing difficulty present in the child. Past history goes on like he has recurrent wheezing episodes since 4 years of age. He has multiple exacerbations in the last 1 year, which includes 3 emergency room visits, and there is 2 hospital admissions during the last 1 year, including 1 ICU admission. He had 2 courses of oral corticosteroids in the last 1 year. So he was started on MDA since 5 years of age. Currently, he is on MDA Furocort 100 mcg, 1 puff twice daily, and he is also on reliever salbutamol as needed. Despite this current medication, he has symptom control. So birth and development history, he's first born to 3rd degree consanguineous marriage. He was born at term with a birth weight of 2.8 kgs. There was no NICU stay. His developmental milestones are appropriate for age. He is currently studying in 4th grade with recurrent school absenteeism in the last 6 months. His family history, his father has history of allergic rhinitis, and the maternal uncle has history of asthma. There is no family history of tuberculosis, and there is no family history of other chronic lung disease present. Socioeconomic and environmental history. He's from a lower middle socioeconomic background. He lives in an urban area. He has exposure to household dust, and there is occasional passive smoking exposure in the household from relatives. There is no pets at home, no exposure to pigeons or parrots. So summarizing the history, he's a 9-year-old boy who's known asthmatic since 4 years of age. He presented with progressive worsening over the last 6 months. He's having nearly daily cough and wheeze with nocturnal awakenings, exercise limitation, and frequent reliever use. He had recurrent exacerbations requiring emergency visit and systemic steroids despite controller therapy, which suggests severe poorly controlled asthma. So the discussion point here would be the markers of poor symptoms control, which includes daytime symptoms for more than twice per week, including night awakenings, frequent SABA use, activity limitation, exacerbations requiring oral steroids, and hospital admissions. So here the future risk is predicted by recurrent use of SABA and recurrent hospital admission, which was twice in this child, including 1 ICU admission. And he also required twice the use of OCS in the last one year. So the important concept that should be kept in mind in this case is poor control is always not equal to severe asthma. So most children, they'll have modifiable risk factors, and it is always important to reassess the basics before stepping up the therapy. So it is important to revisit the history if there is any doubt in before confirming the diagnosis. It is important to check the technique every time the patient comes to the OPD and check the adherence. In case there is a problem in adherence, it is important to approach the patient to address the issues, and also it is important to address the exposures and comorbidities in a child. So the clinical examination, general examination, the child was conscious and cooperative. Allergic shyness were present, suggestive of allergy, and there was no pallor, cyanosis, clubbing, lymphadenopathy, or edema. There was no respiratory distress. The child was able to speak in sentences. The child was vitally stable with a respiratory rate of 25 per minute. So anthropometry and inspection, the child had a BMI of 14.3 kg per meter square, which was at the 25th percentile. On inspection, there was no tachypnea, there was bilateral symmetrical chest movements, there was no subcostal retractions, there was no chest deformity. Systemic examination, the child was on examination, trachea was central, chest expansion equal, bilateral resonant node on percussion, bilateral diffuse polyphonic wheeze, bilateral air entry present, there was no focal crepitations. Other systemic examinations were normal. So in summarizing the examination, the child had bilateral diffuse polyphonic wheeze consistent with a background of poorly controlled asthma from history. There was no clinical evidence of cardiac disease, focal infection, and other systemic involvement in the child. So investigations, we proceeded with phenotyping and other risk markers, which included spirometry. It showed a FEV1 of 59%, suggestive of obstructive airway disease. And the child showed bronchodilator reversibility of 16%, and a pheno of 50 parts per billion, and peripheral eosinophils and total IG were significant, which was 500 cells and 1500 IU respectively. The child had allergen sensitization to dust mite for all the 3 species by skin prick test. The workup for ABPA, which is essential in severe asthma, was negative. So this was the pulmonary function test of the child. On the right side, we can see the volume time curve. And for a child less than 9 years of age, the child should be at least able to blow for 3 seconds, and plateau, and more than 9 years, at least for 6 seconds. Here there is a good plateau. And on the left side, there is a flow volume loop showing scooping in the expiratory limb, which is suggestive of obstruction. So here the FEV1 was 59% of the predicted value, and FEV1 by FVC was 0.69, which is suggestive of moderate to severe obstruction. And the Z-score is less than 2. So the detailed history to be obtained is medication adherence, spacer usage, inhaler technique assessment, environmental triggers, school absenteeism, exercise tolerance, and sleep symptoms are essential. So the key findings in this case includes the child had exposure to indoor allergens where father smokes indoors. There's frequent missed controller doses and incorrect spacer technique and allergic rhinitis symptoms. So inhaler techniques, it is always important to keep in mind, never believe until you see it. So every time it is important to check the inhaler techniques when the child comes to the OPD, no matter how long the child has been using the inhaler. So here poor spacer seal and rapid inhalation was present, no breath hold was there, and the child was also having irregular use and so it is always important to give a repeated demonstration to the patients. So environmental trigger control, it is the triggers present in this child was like a smoking cessation should be emphasized, and dust mite reduction strategies because the child had sensitization to all the 3 species. It is important to avoid other indoor aerologens like incense and smoke exposure. And generally, it is also important to assess pet exposure and hidden triggers. So comorbidity assessment, here the child had significant allergic rhinitis for the past 2 years, and other comorbidity assessment to be made is obesity, obstructive sleep apnea, GERD, and psychological stresses. So the management strategy done in this child was, we made sure the child had correct demonstration of the inhaler technique was done, and adherence was improved, and allergic rhinitis was treated appropriately. Environmental control was emphasized, and the child has been on regular follow-up 6 weeks once, and still the child is having uncontrolled symptoms. And after the phenotyping, the ICS was stepped up to maximum dose of 400 micrograms per day, which was medium dose according to the age of this child. And later, when the symptoms were uncontrolled, despite making all the changes, it was escalated to 600 micrograms per day of ICS plus LABA, which is high dose for this child. So follow-up after 6 weeks, the child had marginally reduced night symptoms, but not substantially. Exercise intolerance was still present, reliever use was still high, and exacerbations during follow-up was still present. So the lung function after stopping the Forocort for 24 hours before the repeat lung function showed FEV1 unchanged, still at 60% of the predicted value, and persistent symptom burden despite partial improvement, and severe asthma workup was required. So currently, the child is on 4-step, and after phenotyping and high escalation to higher dose, currently the child is on step 5 of GINA. So conclusion, it is confirm asthma diagnosis. It is important to revisit the history every time and assess control and future risk, identify modifiable risk factors and correct them, optimize basics first, reassess response, escalate only if genuinely severe asthma persists. And this case ultimately represents a child with likely severe type 2 high allergic eosinophilic asthma. He is a potential candidate for biologics after optimization failure. Thank you.
Vivek sir, you're muted, sir.
Thank you, Keetana, for the elaborate presentation. So, Dr. Keetana set the tone for an interesting case, which we have seen the journey of the case scenario with from basics to phenotyping the child, and with what is the plan currently as per the current GINA 2026 guideline. Child is on step 5 of therapy. So I will hand over the next half of the session to Dr. Kavita, who will briefly come to this case in between her presentation, and she'll get from the basics to biologics, and with a 10-step approach, which we will see through the journey of her presentation. I'll hand over to Dr. Kavita. You can start sharing your slides.
Okay, sir. Is my slide visible, sir?
Yeah, your slide is visible.
Good evening, everyone.
Kavita, you can switch on your screen as well.
Okay, sir. Good evening, everyone. Myself, Dr. Kavita, DNB second year postgraduate from Rainbow Children's Hospital. I'm here to speak on the topic, practical approach to uncontrolled asthma in children. Starting with the diagnosis, we have subjective and objective diagnosis. In subjective diagnosis, we take a detailed history. The patient presents with typical variable respiratory symptoms like wheeze, shortness of breath, chest tightness, and/or cough. And these symptoms usually vary over time and intensity. They are worse at night and in the early mornings. They are often triggered by exercise, laughter, allergens, and on exposure to cold air. And very distinctively, they worsen at the end of exercise. And they also appear or worsen with viral infections. Objective diagnosis, we confirm the variable airflow limitation. We look for bronchodilator responsiveness. We see an increase in FEV1 of more than 12% predicted or PEF of more than 15% from the baseline. Then it is termed as positive bronchodilator responsiveness. And we also check for diurnal variation over 2 weeks period. In positive bronchial provocation test, there is a fall from baseline in FEV1 of more than 12% predicted or fall in PEF of more than 15% with standardized exercise challenge. In the last test shows that after 4 weeks of starting ICS containing treatment, there is an improvement in the lung function test. There is an increase from baseline in FEV1 of more than 12% predicted or PEF of more than 15%. So uncontrolled asthma, difficult to treat asthma, and severe asthma, all these are not one and the same. We have separate definitions according to GINA 2026. Uncontrolled asthma is an asthma where frequent symptoms and/or flare-ups are present. This may be mild or easy to treat asthma with appropriate management. Difficult to treat asthma is not a difficult patient. It is an asthma which is uncontrolled despite starting the child on medium or high dose ICS LABA. It also includes incorrect diagnosis, poor inhaler technique, poor adherence, comorbidities, and SABA overusage. Severe asthma, on the other hand, is an asthma which is uncontrolled despite maximal optimized therapy and treatment of other contributory factors, and the symptoms worsen when the high dose of ICS is decreased. And severe asthma is relatively refractory to corticosteroids and is a retrospective definition. So where do we fit our index child? So he fits into severe asthma, as he had uncontrolled symptoms despite starting on high dose ICS and after controlling the contributory factors. So how common is severe asthma? So these green dots represent 24% of the asthma patients who are undergoing step 4 to 5 treatment according to GINA guidelines. And out of those, only 17% have difficult to treat asthma. And out of those blue dots, we have only 3.7% who have true severe asthma. So severe asthma is not a difficult patient. So why do we talk about this? Because of the impact it creates on the patient's physical and mental health. The patients undergo a lot of symptoms and frightening, unpredictable exacerbations, and it also affects their psychological well-being. It also adds to the adverse effects of corticosteroids we start on. And severe uncontrolled asthma accounts for more than 60% of total asthma healthcare costs. So what are the characteristics of children with severe asthma? So what did our index child have? He had less asthma control, more hospital admissions, including ICU admissions. He had atopic symptoms. He had exacerbations, worse pulmonary functions. He had exposure to tobacco smoke, and they were which adversely affects the quality of life. And this slide shows the age group from preschool to adulthood. Viral recurrent wheeze is more common in the preschool age. TH2, I'll elaborate about what TH2 high and what TH2 low is in the upcoming slides. This TH2 high is commonly seen in children with mild allergic asthma, severe asthma with multiple allergies, and they respond well to inhaled corticosteroids. And this red box, which represents severe non-allergic neutrophilic asthma, is a TH2 low asthma, and their response to ICS is very poor. So coming to the approach proper, we now look at the 10-step macro pathway. The phase 1 includes investigation and management, phase 2, assessment and treatment of the phenotypes, and phase 3, management and monitoring overall. Phase 1 includes 4 steps: confirming the diagnosis, managing the modifiable factors, optimizing the baseline treatment. We should first confirm the asthma diagnosis because we also have symptom overlap and mimics. We have cardiac diseases, obesity. We should look for these symptoms if patient presents with dyspnea. And we also think of VCD, GERD, and bronchiectasis and use of AC inhibitors if a child presents with cough per se. And we also think of tracheobronchomalacia in case of wheeze. Coming to the modifiable risk factors, about 80% of the patients have incorrect technique. So at each step of every visit, we should look for the technique and we should give them asthma education. And adherence is also very poor. It is up to only 75%. How do we check for adherence? We do a phenosuppression test. We give a high dose of ICS adding to the maintenance therapy which they are undergoing for around 5 days to 1 week. And if on repeating the test, if the pheno levels are suppressed, then we confirm that the patients were on poor adherence. And we also check for the comorbidities like chronic rhinosinusitis, GERD, OSAs, laryngeal obstruction, obesity, depression. And we also check for the triggers and meds and we stop them accordingly. We also check for smoke exposure, NSAID usage, beta blocker usage, and allergens relevantly. What is SABA threat? Dispensing more than or equal to 3 SABA canisters per year or more than 12 canisters per year, which is almost 1 canister per month, and it substantially increases the risk of death among asthma patients. Step 3 includes optimizing the management. We optimize their pharmacotherapy. We start them on MARC therapy, ICS with formoterol. And then we address the comorbidities as mentioned earlier. And we also give them non-pharmacological advice. We stop smoke exposure, ask them to start on physical exercise if they are obese, and we ensure vaccinations are up to date, and we advise them yearly influenza vaccinations. And as a baseline test, we initiate them on short term of 3 to 6 months of high-dose ICS LABA if it was not currently used. So this slide tells about the type 2 specific phenotypes and their non-biological treatment. Aspirin exacerbated respiratory disease, we add them on leukotriene receptor antagonists like montelukast to suppress the LOX pathway. And in case of allergic bronchopulmonary aspergillosis, we consider adding oral corticosteroids plus or minus antifungal agent. And in patients with chronic rhinosinusitis with or without nasal polyps, we start them on intranasal corticosteroids and in surgery if it's indicated. And for atopic dermatitis, we start them on topical steroidal or non-steroidal therapy. Allergen immunotherapy, I'll discuss this at the end. This is used only when asthma is well under control. So we should always consider a child with severe asthma. We should always consider ABPA, as we did in our index child. So what is the current diagnostic criteria? According to 2024 revised ESHAM criteria, we have essential and other components. Essential components include Aspergillus fumigatus specific IgE more than or equal to 0.35 kilo units of allergen per liter and serum total IgE of more than or equal to 500 units per ml. Out of the next 3, any 2 must be present. Positive IgG against Aspergillus fumigatus, blood eosinophil count more than or equal to 500 cells per microliter, and CT findings consistent with ABPA. We also can have normal CT findings in ABPA. Coming to the 6-month review note, after optimizing the therapy, we start them on high-dose ICS LABA, and we wait for 3 to 6 months and then revisit the child. We check if the asthma symptoms are controlled or no. If it's controlled, then we consider stepping down the treatment. We stop the OCS first, and we don't stop ICS LABA at any stage. And if it's not under control, then we label them as a case of severe asthma. And we also ask if Does the asthma become uncontrolled when the treatment is stepped down? If it's a no, then we continue optimizing the management. And if it's a yes, we label them as severe asthma again, and then we refer to a specialist. Coming to phase 2, we will further investigate the child, assess the phenotypes, and we start them on biological or non-biological therapy. So coming to the clinical investigations, we do a chest X-ray if it was not previously done, and we also take a HRCT to look for ABPA or EGPA changes, and we also do bronchoscopy to look for tracheobronchomalacia. We do specific IG allergy testing if not done already, and we also do sputum induction to look for MAC. And DEXA scan is done, and morning serum corticosteroid is also done to look for steroid adverse effects. And this parasite protocol, we test for eosinophil count, and if the eosinophil count is more than or equal to 300, we check for parasitic infections, because untreated parasitic infections combined with oral corticosteroids or biological therapy can lead to disseminated disease. If the eosinophil count is more than or equal to 1500, we think of eosinophilic GPA. So what is cumulative steroid exposure? When prednisolone equivalent is taken more than or equal to 500 mg per year, and there is also 2 to 4 short corticosteroid bursts per year, depending on the dose and duration. So this threshold is commonly used as a trigger for steroid sparing review. Specialist reassessment is done, and severe asthma evaluation, biological eligibility discussion is done further. So this slide tells about the steroid adverse effects, which includes osteoporosis, fragile fractures, cataract, glaucoma, and metabolic side effects like obesity, diabetes, adrenal suppression. Even short-term corticosteroid therapy can increase the risk of infection and thromboembolism. This is type 2 inflammation dashboard, which I was talking earlier. So we check for blood eosinophils, pheno, and sputum eosinophils. Blood eosinophils has to be more than or equal to 150, pheno more than 20 parts per billion, and sputum eosinophils more than or equal to 2%. If it's present, then we label them as type 2 high inflammatory asthma. If the levels are low, if a single level is low, we do not name them as type 2 low, but we repeat the test up to 3 times. And if the child is on inhaled or oral corticosteroid, we put them on lowest dose possible and repeat the test after 1 to 2 weeks to look for the increase in eosinophil count. So we name them as type 2 high asthma if the blood levels of eosinophils were high, and low asthma if levels were low, and this non-type 2 severe asthma is often neutrophilic driven. Coming to the management of non-type 2 asthma, it is neutrophilic driven, it is also paucigranulocytic. So again, starting with the basics, we reevaluate them, we reevaluate the diagnosis, we check their inhaler technique, we check their adherence and other exposures, we stop them, and we treat the comorbidities here again, and we try to add on LAMA or try a low dose of azithromycin. And step 3, it shows bronchial thermoplasty, which is just a theoretical consideration, and safety profile in children is not yet established. So what is bronchial thermoplasty? Just it uses thermal energy to decrease the thickness of these smooth muscles. So during inflammation, the airway narrowing is reduced. And as a last resort, we start them on oral corticosteroids. Coming to type 2 high inflammatory pathway, epithelial cells on triggering, they release TSLP, which is thymic stromal lymphopoietin, which triggers the dendritic cells to program the Th2 cells, which then produces the IL-4, IL-5, and IL-13. IL-4, it then binds to IL-4 receptors and stimulates the JAK-STAT pathway, which promotes the B cells to undergo immunoglobulin class switching, where IgE is produced in enormous amount. This IgE then binds to the receptors and binds to the mast cells and basophils and sensitizes the body to further allergen exposure. This IL-5, it binds to IL-5 receptors on the eosinophils and causes the maturation of them and release the toxic granules like major basic protein. So this slide also shows the biological therapy, where anti-TSLP, tezepelumab, breaks the chain at the start of the pathway, and anti-IgE, namely omalizumab, blocks the free IgE receptors, and anti-IL-4 receptor alpha, dupilumab, it blocks IL-4, and anti-IL-5 or 5R alpha, namely mepolizumab, benralizumab, reslizumab, triggers the apoptosis or binding of IL-5. So where does our index trial fit into? So these are the phenotypes. After explaining the phenotypes, I'll tell where our index trial fits into. So a child with childhood onset asthma and allergy-driven symptoms, we start them on anti-IgE therapy if their sensitization on skin prick testing or specific IgE is positive. And we consider anti-IL-5, namely benralizumab or mepolizumab, if child has higher blood eosinophil, more exacerbations in the past years, adult onset asthma and nasal polyposis is present. And higher blood eosinophils, higher pheno and nasal polyposis, these are the criteria for starting anti-IL-4 receptor alpha, dupilumab and anti-TSLP tezepelumab. For this anti-IL-4, we also start them if they have atopic dermatitis-like symptoms. So our child had allergic rhinitis and it was a childhood onset asthma. So we started him on omalizumab. So this slide sums up the previous slide. This is a slide on the biological treatment. Tezepelumab, apart from this, all the other drugs are indicated in children more than or equal to 6 years. Tezepelumab is indicated in children more than 12 years of age. It is mostly used in severe allergic asthma, and omalizumab specifically is used in perennial allergens, as we did in our child. As I mentioned earlier, dupilumab, we start them if patient has atopic dermatitis phenotype. Now, after starting, we check for the response after 4 months of treatment. We look for the decrease in the exacerbations, and we also do a asthma control test where we give a questionnaire and ask them, and we check for the response to the treatment. And if then we look for improvement in the lung function test. Coming to the side effects, omalizumab, it causes arthralgia, headache, and fatigability, and dupilumab is known for its conjunctivitis. So this is a guide on omalizumab dosing. It varies with weight as well as the initial IgE levels. Dupilumab is given in children between 6 to 11 years of age as a subcutaneous injection. In children weighing more than or equal to 15 kgs but less than 60 kgs, we start them on an initial dose of 300 mg at an interval of 2 weeks. And then we give them 300 mg subcutaneously every 4 weeks thereafter. In children weighing more than or equal to 60 kgs, we start them on a double dose, and 2 weeks later, we continue with 300 mg dosing every 2 weeks thereafter. So after starting biologicals, we see for response at 4 months of treatment. If there is good asthma response, if it's unclear, then we extend the treatment to next 6 to 12 months. If it's good response, then we continue the treatment, and then we start to taper the OCs, and we do not stop ICS LABA at any stage initially. And if they are not responding to treatment, we stop the biological therapy. According to NIMBLE study, a patient with severe eosinophilic asthma and a good response to mepolizumab or benralizumab and randomized blind control, we continue or switch to depemokimab, because depemokimab is a long-acting anti-IL-5 biological therapy, which is given in children more than 18 years of age, and since it's long-acting, it's given only 26 weeks once as a subcutaneous injection. According to 2026 GINA updates, we also have a triple therapy indicated in more than 12 years of age group, where LAMA is added to ICS LABA. We also have a new biosimilar anti-IgE, omalizumab IJEC, which has the same indications as omalizumab, but the pricing is on the lower side. So we have to revisit this symptoms and the exacerbation history. We also have to ask for the reliever usage when the patient visits every time. There are no particular guidelines as of now on what is a good response to biological therapy. We ask for the patient satisfaction and their improvement in symptoms and lung function. Step 9, if patient is not responding to type 2 targeted therapy, we stop the biological therapy. We review the basics again. We start with the differential diagnosis. We diagnose the asthma if it's right or no. And then we check their inhaler technique. We check for the comorbidities, adherence technique. And we also give them emotional support. We also consider HRCT if it was not done previously. And then we consider all the other comorbidities. And then we start them on low-dose azithromycin. And then we stop ineffective add-on therapies But as I said previously, we do not stop ICS. So this slide sums up the optimization. We ask the patient to come for a regular visit every 3 to 6 months once, and we check for their symptom control and improvement in lung function. And we also check for their comorbidities and treat them accordingly. And in case of patient taking corticosteroids, we check for the adverse effects. So a short note on SLIT. So what is SLIT? It's a sublingual immunotherapy where a small amount of allergen is given on a daily basis, and it changes the allergic response to a long-term tolerance. And it profoundly modifies immune response to allergens. It is given as sublingual tablets or liquid drops, and it is used in asthma and in allergic rhinitis. So can we consider this in our index child? No, because his FEV1 was not much higher as indicated for SLIT therapy. Yeah. It was less than 70%, and his asthma was not well controlled. Concluding, Tier 1, we start them on ICS formoterol MART therapy, and then we switch them to, we increase the dosage of ICS LABA if not responding, and then we try adding on low-dose azithromycin or LAMAs, and then we switch them to biologicals if possible, if they have local payer or eligibility criteria based on their phenotypes. And as a last resort, we start them on oral corticosteroids. Thank you.
Thank you, Kavita, for your detailed discussion from the basics to biologics, and particularly your slide on the targeted biological therapies and in the cascade where they act was very impressive. Going on to the last 10-15 minutes of the session, I would like to invite Professor Srinivasan sir, followed by Dr. Jagdish sir, and then SBS sir for their expert comments, reviews, and their feedback. Can we start with Srinivasan sir first?
Srinivasan sir is mind-boggled. I learned so much advances, and I felt, probably I didn't know anything about asthma, especially in this current century. So that is my comment. Excellent presentation, and I'll try to keep up and try to. I think this is an eye opener for me. Excellent presentation and very well done.
Thank you, sir. Jagdish sir, we would like to hear your comments and your feedback and your on your opinion also, sir, regarding this case as well as your on difficult asthma.
Yeah, thank you. Thank you very much, Dr. Vivekanand. And both of you presented the case really, the case was presented very well and excellent. The whole way in which you took it from the basics to biologics was really excellent, Dr. Kavita. Very good slides too, very nice. A few points that I had was the first thing that we need to consider is that GINA is not guideline. GINA is a strategy. So if you look at the publication of GINA, it doesn't say it's a guideline. You have to put this guideline into your practice. Rather, the strategy has to be applied into your practice. Some of the points which I felt could be a little different from what was presented was, the first thing that I saw was that there was a significant amount of sensitization to house dust mite in this child. And I think unless you get rid of that, you can go on giving whatever biologics or whatever else you like, but that is not going to make, it may make a difference temporarily, but unless you get the source control of the allergen very rigorously, you are going to get, again, this child is going to keep coming back to you. So the first thing that I would do is to physically go or send somebody to inspect the house and see what are the potential sources of allergen in this house, because that needs to be controlled first. Because if this child is, see, the point is you can talk to them about allergy control, but actually getting rid of all the sources of the house dust mite in a house is extremely difficult. I will just tell you a small story. I had a child who was 9 months old, was coming to me with recurrent wheezing right from the age of 7 months onwards. This child had no atopic dermatitis, nothing else, but came every time with wheezing, was given, inhaled corticosteroids, inhaled beta-2 agonists, admitted once for, severe wheezing. And then what we did was we sent somebody to look into the house and see what was going on. This child was crawling on the floor, which was being treated by a chemical. Means this cleaning was done with a chemical which contained VOCs. And after stopping that, this child has had a wheeze for the last 3 years. So a simple environmental control is extremely important. And I would not, emphasize more on that. The next thing that I would also want to emphasize is the use of the peak flow meter. I think Gina has emphasized that now. And I think in this child, when you send the child home for 6 weeks, do not wait for 6 weeks for this child to deteriorate. You need to monitor what's going on with the peak flow. So I think that's something that the parent should be taught, and to come back immediately if the child does not breathe adequately or blow adequately. So that's the next thing that I would look at. The fourth important thing that I would look at is, see, when this child has had 2 admissions and is constantly sick, the family is under a significant amount of psychological distress. This is where these patients will disappear to other pathies. They will go to naturopathy, they will go to homeopathy, they will go to other pathies. So a psychologist handling this family is extremely important, because they need to persist with the treatment. And remember one thing, the biggest stress in our population is management of chronic disease. So I would get a psychologist to look at the child and the family and tell them that, yes, we have not yet solved the problem, but we are on the right route and we will help your child out. So that is an extremely important part of counseling that you need to look at. And finally, this child has had nutritional problems. So therefore, it's extremely important. This child has got, so that you please also look at other things like anemia, vitamin D deficiency. All this can come in, because we know that severe asthma and persistent asthma can lead to growth failure. And this could be the reason for the growth failure too. So you need to look at the nutritional aspects too here. So look at this child as a whole, look at all the factors here, and then take a call. Again, the last point I would say is biologics are very good in a very select, small, few children. Do not try to say that just because this is type 2, TH2 predominant, phenotype, that you've got a high, eosinophil count, and your parts per billion are more than 50. You want to put this child on a biologic. Please, no. Ultimately, leave that biologic decision to an expert like Dr. Vivekanand or a pulmonologist. For the average general pediatrician, a biologic is a no-no, please. Because this needs to be given only in a select few. That choice has to be made by somebody who has been handling such severe patients all the time. So these are some of my comments. So thank you.
Thank you so much, sir, for your great feedback. We will address all the social factors as well as the psychologist perspective, definitely, sir. Thank you so much, sir. And SBS, sir, we would like to hear your valuable thoughts, feedback, and your suggestions, sir.
SBS sir?
Am I audible now?
Yes, sir. Yes, sir.
Yeah. Okay. Now, yeah, thank you. See, after I spoke to Vivek, yesterday I thought I will just do some surfing in the net about recent advances. Though many new points have been stressed, for the average pediatrician, when an asthma appears to be uncontrolled, I still remember one old mnemonic which I continue to find it very useful even today. It's called SPICE, SPICE. Vivek, SP SPICE is symptoms, P S stands for symptom, P stands for physical examination, and I stands for inhalation technique, and C stands for compliance, and E stands for environment. If you ask me if you are going to, a general pediatrician is going to see, say, 20 cases of what looks like poorly controlled asthma, 90 to 95% of them will be well controlled if the general pediatrician pays proper attention to spice. Now, that was illustrated very well by Dr. Jagdish when it came to environmental manipulation. In fact, one of the things which nowadays I find in my practice, people have become more fond of rearing pets in the house than children, right? Lovebirds they keep. The history, unless you ask, they will not. You normally we ask dogs are there, cats are there, but we don't ask about lovebirds, parrots, pigeons. Okay, and more importantly, people living in flats. Another hypersensitivity we should not forget is pigeon. Okay, that history should be obtained in addition to passive smoking, which we take. But it is often joked that in the West, if there is a female adult asthmatic, if the pulmonologist says, you get rid of your cat, the answer from the middle-aged woman would be, I would get rid of my mother-in-law, not my cats, right? So that's very important. That's very important. Dogs, cats, and it's not enough. Even if dogs and cats are there in the house, there are scientific ways of keeping the children away from the allergens from the source of cats or dogs. That is one comment. The second comment, in the recent Lancet respiratory medicine issue, I was very, very impressed with one of the review articles on inhaled corticosteroids, where two individuals have actually traced the story of inhaled corticosteroids from the first trial to the latest trial. And one study which has been published, which is the article is still in the press in the Lancet Respiratory Medicine, is called Sunrise Study, in which the authors comment that a cumulative dose of 0.5 to 1 gram of inhaled steroids, whatever it is, whether it's budesonide or cyclosinide or fluticasone, once it exceeds 0.5 grams, even in an adult, the side effects are very severe. So imagine an adolescent girl, 1 year on budesonide, 2 puffs or 1 puff BD for a year or two will almost receive 0.5 grams, and the effect on the bone health is often ignored. That is an interesting thing. And they have they report a study called Sunrise Study, that interestingly, most of the trials in asthma have always followed some names. Just to trace it, the first study on the efficacy of budesonide was CAMP study, then START study, steroid treatment as regular therapy, then PAC study, pediatric asthma controller trial, and then Badger study, best add-on therapy, where they came to a conclusion that, you add formoterol, it's more helpful. And then FACET study and Optima study and so many other Sunrise study. Very interesting to go through all the abbreviations for all these studies. And this Sunrise study, where they used tezepelumab, it's actually a biologic targeting thymic stromal lymphoprotein, and it stops the inflammatory cascades. And they found in a long-term trial that it definitely reduces the use of inhaled corticosteroids, right? And my final comment is, even though only a minority of asthmatics will come under the category of poor control or severe asthma, it is the duty of the general pediatrician to recognize such cases and refer to people who can handle this properly, like Dr. Vivek or Dr. Jagdish, so that proper investigations are carried out. But unfortunately, all these biologics are going to cost quite a lot. But the future is very clear. Even for moderate to severe asthma, the first line therapy, if there is eosinophilic asthma, the treatment would be biologics first, and your inhaled corticosteroids may be used only for the first few months and not later. And last comment is, I'm happy that leukotriene receptor antagonists were there sparingly in the presentation. It's Gangapani. It's one of the most useless drugs under the sun. These are my comments. Excellent presentation. Thank you very much.
Thank you very much, sir, for your valuable thoughts, insights on your comments. I would, to conclude, I would just like to re-emphasize what was discussed over the last 20 minutes. Like, asthma is still, it is always getting back to the basics first and revisiting our diagnosis at every step. Rather than, I think we need to always think before we ink on the subsequent doses of steroids, because it, like what was mentioned in the slides, 80% of the time it is poor adherence, poor compliance, and stopping of drugs abruptly, and technique issues, which is always 40. If you take 100 children, 80% of them are invariably doing it wrong, how many times you tell them. And the future holds a lot of promise, particularly with what sir mentioned with regards to tezepelumab, because it acts at the top of the inflammatory cascade. I'd conclude by saying that though severe asthma is a real problem, we don't see the prevalence of severe asthma in a pediatric population in our country or in Asia, particularly in India, is definitely much less when compared to the European or the American population. And I hope all of us are convinced about the journey of the presentation, as well as the basics to cover, particularly from a general pediatric point of view. I would like to invite any other comments from any one of the audience or any other feedback. Thank you for the opportunity.
Thank you so much, sir. I think it's a little intimidating for me to offer my comments, especially when I'm in such illustrious company. But I think for general pediatricians, what you said totally hits the nail on the head. So a child who does not improve despite appropriate inhaled corticosteroids and correct technique should be assessed for an incorrect diagnosis. And I think what we need to remember is that there are some important red flags that point against a simple asthma diagnosis. So if there's a unilateral wheeze or localized chest findings, failure to thrive, clubbing, symptoms since infancy, work up for the masqueraders. And of course, biologics are the way to go. So the N number of MABs that are hard to remember and difficult to pronounce, we will have to learn to live with them, learn to use them. Of course, I guess experts are there for that. So we can simply refer such difficult cases and put our legs up and relax that our patients are in the best of hands. I have a query. Now, what about this pheno? So does the pheno improve with clinical improvement? Does it correlate with it, or it can still, remain elevated even if the child improves clinically?
Kavita, you would like to take the question? Kavita or Kirtana?
Sir,
So
yes.
FeNO improves with the treatment, sir. With OCS, it can decrease. Even with inhalational corticosteroids, it can decrease.
What would you think of if a child who is on ICS doesn't improve with treatment? FeNO still remains high.
We should check for the inhaler technique and adherence, sir. And then
Fine, primarily. And is there any difference in the FeNO cutoff for children who is on not on ICS and who is on long-term ICS?
Yes, sir.
Yeah.
With for children who has never been on ICS, more than 35 parts per billion is considered to be high, and children who are on high dose ICS, more than 20 is considered to be high.
So to sum up, madam, also to diagnose type 2 eosinophilic pathway, type 2 high asthma, as well as to check for adherence and compliance, it is quite a useful tool in addition to spirometry, if the facilities are available.
Thank you, sir. It is just out of academic interest also, and it was a personal question too. We have an audience of postgraduates who have joined on Zoom, and people are watching on our live stream as well. So that is why this question was asked. And let's hear from the horse's mouth something else that the PGs must know about the unified airway and how allergic rhinitis can affect asthma control. Can you just say a few words about it for the benefit of our audience?
Myself, madam?
Yes, sir.
Yeah,
Yes, sir.
sure. So the main question is, Dr. Mahesh sir, Mahesh Babu sir always used to tell the nose is always taken lightly. So children, parents usually raise concerns of uncontrolled wheeze. But if you take 100 children with uncontrolled wheeze, 30% of them definitely will have, or even 40% could have persistent allergic rhinitis. Nose symptoms are usually not brought about elaborately by parents because nose is always taken lightly. It is only with exacerbation and if there is a breathing difficulty and hypoxia, then the attention usually comes. So there is, because it's an unified airway disease with regards to the epithelial lining, the take home would be definitely all children with uncontrolled asthma parents needs to be questioned on repeatedly about persistent allergic rhinitis symptoms or other coexisting atopies as well, because the control could be addressed by attributing to that factor itself.
Thank you, sir. If there aren't any more questions, may I request Sudhakar sir to please offer his comments.
Oh, nothing to more add. Actually, an excellent way of presentation by the postgraduates. Thanks to Vivek, Dr. Vivek, you didn't talk much, but you make your students talk much. That shows you are really.
Thank you,
really,
sir. Like you mentioned, I would like to thank Dr. Kirtana and Dr. Kavita for their excellent presentation and their clarity with which they spoke.
Really, I have to appreciate the clarity in the presentation. And of course, the youngsters, the way of presentation, the slides also. Very impressive slide I have to mention, especially. The slides itself convey the message very nicely, actually. Thank you for your time and valuable guidance for the postgraduates. I'm able to see that number of attendees has increased remarkably compared to previous programs. Thank you from the on behalf of Indian Academy of Pediatrics Chennai City branch. Our special thanks to Jagdish Sinnappa sir for sparing his valuable time. We all know how busy he is, and our teacher, Dr. SPS sir, for guiding all of us, even at this stage. For decades, he's guiding us actually. Still, he's taking time and reading all the articles, recent updates, and updating himself and updating us also. Thank you, every one of you for attending the session.
Good night, all of you.
Good night,
Have a
sir.
great day.
Thank you,
Thank you, everybody.
Thank you so much, sir.
Thank you, everybody. Until we meet next time, good night from the Chennai City branch.
I talked to your father, Varadarajan. So he has sent message immediately.
Thank you,
Yeah,
sir.
I
Thank
sent
you.
a photo also of you.
Thank you, sir. Kind of you, sir. Thank you, sir.
Well done,
Thank you.
Vivekanandan. Well done.
Thank,
And your
thank,
team. Yeah.
thank you, sir.
Good.
Thank you, sir.